Hello, my name's Tim from the 247nursetutors.com. Today, I'm going to be leading you in Cardiac Part 3. Refresh my memory. After what period of time does ischemia lead to actual tissue damage and necrosis? That's right, 20 minutes. Again, for all of these acute cardiac events, time is of the essence. As discussed earlier, occlusion of a coronary artery leads to tissue ischemia and eventually actual tissue death. If cellular death of myocardial tissue occurs, then obviously there will be a decreasing ability of the affected myocardium to function. As more cells die, more myocardium is impacted, and function continues to decrease. This leads to a drop in cardiac output and a drop in blood pressure. As the heart is the pump for our body, other organs are affected as well. For example, if the kidneys experience a significant reduction in cardiac output, certainly anything less than 25%, then acute tubular necrosis can result if this condition persists for more than 30 minutes. What will happen if this is severe and it is not corrected? Correct. Your patient will die. Again, time to treatment is critical. Let's review. Myocardial ischemia is caused by a decreased amount of what? Yes, blood flow and oxygen. After what amount of time is there irreversible tissue damage? That's right, 20 minutes. Unstable angina is defined as angina at rest lasting more than 15 minutes. Myocardial injury occurs when there is no blood flow. This will show as ST elevation on the ECG. STEMI stands for ST evaluation, MI. It is a life-threatening situation and is detected on a 12-lead ECG. Note that ST elevation can also be seen on a common rhythm strip, which would be an indication for a STAT 12-lead ECG. It is important to note that patients do recover from myocardial infarction, particularly with quick treatment and modern therapies. After an MI, scar tissue is formed and those cells are no longer functional. These cells are no longer able to contribute to conduction or contractility. You can think of these individual cells as continually asystolic. Within 24 hours of infarction, the healing process begins. I am sure you know individuals who have had a heart attack and are doing fine. I have seen individuals with very low ejection fractions, well below 30%, still be productive and happy. Granted, they are on medication and possibly other therapies such as home oxygen as well. I also know some that wish they had some lifestyle changes earlier in their life. The window for TPA administration is 6 hours for a myocardial infarction and 3 to 4.5 hours for a stroke. This is still being studied in clinical trials and current research could be considered. MONA is one of the mainstays of treatment. M is for morphine. O is for oxygen. N for nitroglycerin, and A stands for aspirin. BATH. B stands for beta blocker. A for ACE inhibitor. T, thrombolytics, and H, heparin. However, this is not the order in which you should render treatment. You give oxygen first, then nitrates, then aspirin, then morphine. The goals are to decrease myocardial oxygen demand and increase available oxygen. Elderly and confused patients often are unable to describe the symptoms of a myocardial infarction. Women will sometimes not have the typical chest pain, but may describe the pain as coming from the epigastric region or from their back. Diabetics, due to neuropathy, may have decreased or masked symptoms as well. I have had several patients who described a myocardial infarction as really bad heartburn. In fact, some patients may use heartburn as a way to deny the symptoms of a heart attack. There are chemical markers that can be tested to assist in diagnosing an MI: creatine kinase and CK-MB. CPK-MB is the most specific for an MI. It should be greater than 10% of the total CPK for definitive diagnosis. CPK-MB onset is 4 to 8 hours after the event, peaks in 16 to 24 hours, and returns to normal within 48 to 72 hours. Myoglobin is a less specific indicator, but is associated with other markers and can help confirm the diagnosis. Troponin T and I are found only in cardiac muscles. Their initial trending is similar to CK-MB, and if both are elevated together, a diagnosis of an MI can be determined. Troponin T and I remain elevated for 1 to 3 weeks. An ECG is a representation of the electrical activity of the heart and is an essential diagnostic tool. Today, there are many ways to monitor a patient's ECG, including telemetry, Holter monitoring, and wireless monitoring. Isn't technology wonderful? Common changes seen on an ECG that are associated with an MI are ST segment elevation in the leads of the infarcted area, ST depression in the leads 180 degrees away from the area of infarction, and Q waves greater than 0.04 seconds wide. An exercise stress test can be performed to evaluate angina and cardiac performance post-MI. A stress test can be induced pharmacologically using Persentin and Adenocard. The overall goal of therapy is to decrease the workload of the heart and preserve myocardial tissue. Again, time to therapy is critical. There are many treatment options to correct an occlusion. These include a clotbuster therapy, TPA, balloon angioplasty, stents. In the case of angioplasty and stents, the goal is to reopen the occluded area of the vessel. Bypass grafts are often taken from veins in the leg or from arteries in the wrist or chest. These grafts are used to bypass the clot and restore blood flow. Regardless of the therapy used, the goal is to restore blood flow to the myocardium. Congestive heart failure is a result of a loss of contractility resulting in decreased cardiac output. There is a backup of blood into the lungs and increased pressure in the pulmonary system. Because of this, oxygen-carbon dioxide exchange is impeded. As this worsens and pressure continues to increase, the right side of the heart is impacted and the right heart cannot pump blood into the pulmonary system. Venous return is impeded. Pressure continues to back up and eventually other body organs are congested with venous blood. Remember the starting law and the rubber band? What happens if you keep pulling on the rubber? Well, it can eventually break. If the myocardium is overstretched, it will be ineffective and cardiac output will decrease. Starling's law states that the greater the volume of blood entering the heart during diastole, in diastolic volume, the greater the volume of blood ejected during systolic contraction, or stroke volume, and vice versa. There are many risk factors that may lead to congestive heart failure. It is certainly one of the most common issues following a severe myocardial infarction. Other factors include hypertension, family history, smoking, obesity, alcohol abuse, diabetes, sleep disorders, and cardiotoxic drugs such as chemotherapeutic drugs. Cardiotoxicity is damage to the heart muscle or the conduction system due to the use of these drugs. Congestive heart failure can vary greatly in severity depending on the degree to which the myocardium is affected. congestive heart failure can also be progressive and worsen over time as myocardial function continues to decrease. Of course, both sides of the heart can exhibit heart failure. Left side heart failure is mostly manifested by pulmonary symptoms, and right-sided heart failure is mostly manifested by systemic systems. Symptoms of left-sided heart failure include anxiety, dyspnea, cough with a frothy sputum, tachycardia, diaphoresis, rales. In severe cases, this is sometimes called the death rattle, wheezing, cyanosis or pallor, and palpitations. Symptoms of the right-sided heart failure include hepatosplenomegaly, with or without pain, pitting edema, jugular venous distension, bounding pulses, and dysrhythmias. And of course, a patient can have both. In general, diagnostics will be indicative of those systems that are affected. An echocardiogram will demonstrate a decrease in cardiac function. Arterial blood gases will demonstrate decreased oxygen and carbon dioxide exchange. An ECG may demonstrate changes associated with a previous MI or signs of chamber enlargement. Hypothyroidism may be a contributing factor. An elevated creatinine suggests renal impairment, and a CBC may suggest infection. Other diagnostic tests may be performed to evaluate other systems that may be impacted. These may include chest x-rays, renal studies, and liver function tests. Congestive heart failure is treated with ACE inhibitors, beta blockers, diuretics, and digoxin. ACE inhibitors relax blood vessels and lower blood pressure. Capitan and Vasotec are two common ACE inhibitors. One side effect of ACE inhibitors is angioedema, which may prompt a visit to the emergency department. We have discussed beta blockers briefly earlier. These slow the heart rate and also reduce blood pressure. Atenolol is a very common prescribed beta blocker. Diuretics simply reduce the amount of circulating fluid. Electrolytes need to be monitored with the use of diuretics. Digoxin is still a mainstay of therapy for congestive heart failure. It improves cardiac contractility and decreasing heart rate. Digoxin levels need to be monitored periodically. An ECG should be evaluated periodically as well. Pericarditis is an inflammation of the pericardium. It can be caused by infection, post-op chest surgery, trauma, cancer, and radiation therapy. It can be very painful, particularly on inspiration. A squishy sound indicative of a pericardial friction rub can be osculated. Endocarditis is typically caused by an infection and can lead to damaged heart valves. Symptoms may be difficult to differentiate from other illnesses and include a slow onset, a low-grade fever, fatigue and malaise, chills and sweats, and murmurs. Treatment is antibiotic therapy and medication for pain relief for both. If invasive procedures need to be performed on these patients, antibiotics are recommended. There may be a need for long-term anticoagulant therapy if valve replacement is performed. ECG should be monitored for AFib, which might indicate thrombus formation. As mentioned before, prophylactic antibiotic therapy is needed before any invasive procedure. The patient should be taught the signs and symptoms of pericarditis and endocarditis so that they can recognize these if they occur. Both of these can range from mild discomfort to extreme pain. Appropriate pain management is essential. We have discussed the cardiac valves in some detail previously. Remind me, which valves are the AV valves? That's right, the mitral valve is on the left and the tricuspid valve is on the right. Okay, so which are the semilunar valves? Yes, the right one is the pulmonary valve. The left one is the aortic valve. Regurgitation is when the valve doesn't close tightly, allowing blood to flow backward. Stenosis is when there is a narrowing of the valve. This abnormal valve doesn't open properly, blocking blood flow. Symptoms for valvular heart disease are related to the valve or valves affected. For example, in mitral stenosis, there may be fatigue, dyspnea, orthopnea, a cough, or pulmonary edema. Atrial fibrillation is common in mitral stenosis. A murmur is often associated with valvular defects. Peripheral vascular disease is caused by the same mechanism as cardiac disease, except that the vessels that are affected are in the periphery. The risk factors are also the same. This means that vessels either become blocked, narrow, or spasmed. The symptoms and treatment for these are listed in the table on your screen. The most common symptom is claudication. Claudication is lower limb muscle pain when walking. It usually goes away after some rest. Similar to angina in the cardiac setting, claudication occurs when there's not enough blood flow to the muscles being used. Surgical treatment may include angioplasty and bypass grafts. Congratulations! You have completed the cardiac unit. You will be successful.